Good morning, everyone. I'm Dr. Toni Jennings, a clinical audiologist with the University of Texas Medical Branch, based out of Galveston, Texas. In this role, I have the privilege of working with all patient populations in a mostly outpatient clinic setting. Today, we'll be visiting the topic of pediatric hearing loss. Much of what we will be discussing today comes from years of being in the field, attending continuing education courses, and working closely with a host of other professionals. We have the opportunity of working with ENT, pediatrics, speech-language pathology, genetics, educational, and other clinical audiologists very closely. A great deal of what you will hear today has been studied, written about, studied again, and rewritten. However, I will not be talking about any one specific research or school of thought. Most everything today is anecdotal and comes from previous experience. So let's get started. I do not have any financial or non-financial disclosures, but as I stated earlier, I am employed as an audiologist with the University of Texas Medical Branch. Our objectives today are to provide a review of issues specific to the pediatric population. I hope that by the end, you'll feel more comfortable with the developmental milestones and hearing loss impacts that may be seen in the pediatric patient. You should have a slightly better understanding of social and educational considerations, and you should have working knowledge of available resources and be able to screen for hearing or developmental concerns to determine the need for further referrals or management. So let's get started by talking about some numbers. Keep in mind, some of this data is extremely old and may but well be an underestimation of current trends. However, I had a hard time finding clear and concise data that was current. That could either mean that I wasn't looking in the correct spot, or we need to get more people and more money evaluating some of these areas. The WHO this year posted that 34 million children worldwide have a disabling hearing loss. They are classifying disabling as greater than 30 dB HL or mild hearing loss. The American Speech Language Hearing Association, or ASHA, reports in the US about 15% of children between the ages of 6 and 19 have hearing loss. And a few years ago, the American Academy of Audiology, AAA, stated that about 12% of children have noise-induced hearing loss. Later today, you'll see another note from the CDC from this year, citing 13% as having noise-induced hearing loss. And as you're probably already aware, children are at a high risk of experiencing otitis media and associated fluctuating or conductive hearing losses. And then in 2002, again, very old numbers, it was suggested that 1 in 7 children with a unilateral hearing loss in only 1 year, will develop hearing loss in the better ear down the road. And for those that work closely with the newborn population or who tend to see some of these younger children, 90% of deaf infants are born to hearing parents. And then from 1974, severe to profound hearing losses was reported to occur in 9 out of every 1,000 school-age children. Additionally, 30% of those children who have hearing loss also have involvement or other diagnoses. So what does all that mean for you or me? It means that we will be seeing a number of children with hearing loss that's caused by a number of factors occurring at any point during their childhood. Some of these children will have hearing loss as the only thing that needs to be managed or followed. For others, the hearing loss is just one more thing in a long list of other things to be managed. As with most things in life, each instance and case will be unique. No one method, intervention, thought process, goal is going to be answered or be successful for each child. We may have to modify and be sensitive to the family's needs, wishes, and desires. My hopes today are that you get a better feel for the general information presented so that you can feel more comfortable guiding families down whatever path they find themselves on. So hearing loss can occur anywhere along these lovely pathways. Peripheral hearing loss is the one that we will be focusing on the most today. This is a hearing loss that occurs because of change in the external, the middle ear, or the inner ear. External or middle ear changes can cause conductive component hearing losses. Hearing loss in the inner ear, as you know, is considered sensorineural hearing loss. There can also be hearing loss further up the auditory system, along the auditory nerve or in the lower brainstem. These are usually classified as sensorineural hearing losses, but sometimes the central loss can also be identified. And I alluded to this a moment ago, but let's expand this conversation a little bit. Pediatric hearing loss can be classified as either congenital, occurring at birth, or acquired, occurring after birth. Congenital hearing loss can occur because of genetic factors. You're looking at your chromosome anomalies, you're looking at associated syndromes or disorders that also have hearing loss. Congenital hearing losses can also occur because of non-genetic factors. Trauma during the birth, anoxia, congenital infection, maternal medical treatment, chemo and radiation come to mind. Other causes of hearing loss are acquired. These are otitis media, head trauma, noise exposure, ototoxic medication use, meningitis. We can classify these hearing losses either transient or permanent. Transient meaning that it's fluctuating or resolving. So traditionally, when someone uses the word transient, we're about a conductive hearing loss that occurs because of middle ear pathology. Once the middle ear pathology is resolved, the hearing is resolved. Permanent is permanent. It's not resolving, it's there, it's something we have to deal with. And quickly, since I'm not sure of everyone's familiarity, conductive hearing loss occurs with air conduction, or when air conduction is abnormal, but bone conduction is normal. And there is a larger than 10 dB decibel air-bone gap or air-bone gap. Examples that cause conductive hearing loss are microtia or middle ear pathology. Sensorineural hearing loss is where air conduction and bone conduction are both abnormal, but air conduction and bone conduction are close together or less than 10 dB apart. There is no air-bone gap. Mixed hearing loss is when you have either air and bone are abnormal and there's an air-bone gap, or you have a combination of conductive hearing loss and sensorineural hearing loss. So an example of this is someone with a permanent sensorineural hearing loss who also has a middle ear pathology. Sometimes the lower frequencies will show that conductive component where the high frequencies will still just show a sensorineural hearing loss. And then also, as I mentioned earlier, you can have hearing loss occurring higher up in the system. The peripheral functions, the middle ear and hair cells are working fine, but along the auditory brainstem or the auditory cortex, there's a misfiring or a transmission issue. This is seen in patients with multiple sclerosis, cerebral palsy, or auditory neuropathy. Auditory processing deficits or central auditory processing deficits can also occur along this system. However, for today, we are mostly going to just discuss the implications of peripheral hearing loss on the pediatric patient's development, academic performance, and social interaction. Before I move too much further, I would like for us to quickly glance at these two graphs. We use these in the audiology world as a counseling tool. We refer to them lovingly as the speech banana. The reason for that is, as you will see, the speech sounds are graphed in the shaded region on the audiogram, and they, as you guessed, look like a banana. These graphs are from two different audiology associations. One's older than the other, and as you will see, there are some slight differences between them on where some of these speech sounds fall. But their goal and their purpose is to show us where speech sounds occur when produced in isolation or by themselves with a normal speaking effort and without any other external influence. These graphs also indicate where some environmental sounds fall when produced in isolation. And if the audio will work, I have some sound bites of what a normal listener should hear. So this is that is a child to a normal hearing listener using just a normal voice. This one is some birds. And this one is inside a train for a normal hearing listener. So those gives you some examples of some different sounds for presented in their normal environment at their normal volume to what a normal hearing person should hear. This is a graphic of the degrees of hearing loss. You've probably heard before that pediatric hearing loss has an additional classification compared to an adult. We use the terminology slight. Slight is not used for adults normally, but it is used for children. The reason that we do use it for children is because we know that they are developing speech and language, and therefore they need to be able to hear some of those soft, unvoiced consonants like our S and our TH and our F and our V. If they have a slight hearing loss because of where those sounds occur in isolation, they may not be getting that information. And so to catch that, we have used a different classification for them. Because we also have a slight classification for pediatrics, the range of mild is a little bit smaller because slight has been included. But the remainder of the audiogram and the classifications, moderate, moderately severe, severe, and profound, remain stable for adults and for children. So the scale is the same. An example of a child that may come in and sometimes will have a slight hearing loss is where a child has been in speech therapy for a while and he is having continued issues producing the S sound, especially at the ending of words. Despite months and months of intervention, sometimes the parents will come in and say, he's been working so hard, but he doesn't seem to notice that they're even presenting the sound. Or you know, he's still omitting those sounds even though they've worked on it and given him lots of support. And sometimes we'll find that they have a slight hearing loss in the higher frequency range. When we talk about hearing loss in the pediatric patient, or when someone says they are concerned about a child's hearing, these are the usual reasons. They're not following directions. They're not listening. They turn everything up. She doesn't seem to be paying attention to me. The teacher says that he's disrupting class. She's requiring us to repeat everything. I don't know what's going on. She was talking so well, and now I can't even understand her. Those are some things that we will see on a regular basis. But hearing loss could be the reason for some of the examples I just gave. Chances are pretty high usually, but also remember that those numbers from the beginning of the lecture. It's not always just hearing. Sometimes there are other factors that are leading to some of those behaviors that parents are reporting. Sometimes it is, hearing is not always the only reason for behavior problems or repetition or not following directions. Sometimes it's the environment. You can have bad acoustics, you can have a really loud background noise. Sometimes it's the speaker. They have poor speaking quality, they're whispering, they're looking away, they trail off at the end of their words. Sometimes it's a distance is an issue. We have expectations that people can hear us, you know, across the room using a normal voice. That's not realistic. Sometimes there may be a behavioral issue at play. It may be that they are seeking attention. It could be that there is the need for attention, or it could be that there is an attention issue of the inattentive type. This is where the audiologist, this is where you guys and gut feelings and listening to the parent report give you that information, and where you know that you need to dive in a little bit more and dig a little bit more to see exactly what's going on and evaluate the situation a little bit better. When it is hearing loss, however, there can be far-reaching impacts, and so we are going to talk about some of these. We're going to gloss over a few because we only have an hour, but we're going to talk about the developmental impact that hearing loss can have, the academic or educational impacts, social and emotional, vocational, and financial impacts. Let's talk about development first. This is a big area. This is an area where there's a lot of variation depending on the child's age. And there is a ton of information available. Pediatrics and speech pathology have a ton of resources available for families, for professionals, so that we can all be on the same page and can also know what is normal so that we can identify what is abnormal. When we talk about speech and language development, usually the first thing that comes to mind is articulation errors. You know, this child, he or she just started school. They're having difficulty saying certain sounds. Their speech is unclear. And as the novice listener, the new person in their environment, you're struggling to understand what they're saying. You look to mom or dad to kind of help you fill in those gaps. There are also those other cases where you have an older child who has difficulty following simple instructions or can't express themselves. They have maybe a diagnosed receptive or expressive language delay. These pictures are back up because try to picture them as we talk a little bit more. The examples I gave were for older children, but what about our itty bitties? How do you know if they're having delays in their development? How do you know if their delay is because of a diagnosed hearing loss? So glad you asked, because here are some developmental milestones that are readily available through early childhood intervention programs and pediatricians. I'm starting with the 3-year-old group here and working to the younger because I want you to see a pattern. The items in blue are items specific to speech and language development or auditory milestones. Children with hearing loss will show delays in these specific areas because of the hearing loss. The delays may be minor or they may be severe. That will depend on the degree, the type, and the configuration of the hearing loss. It will also be dependent on external factors, parent and caregiver involvement, their access to auditory examples. Does someone read to them a lot? Does someone do pretend play with them? Those things will all affect their ability to develop some of these skills. Duration and frequency of the hearing loss will also have effects. The longer there's been a hearing loss, the longer it's been untreated or unnoticed, the more significant you can expect the delays to be. Other involvements as far as other pathologies, other developmental concerns, syndromes, that will also play into this level of achievement. But children that are getting a lot of interaction, getting a lot of support, even if it's not professional support, but getting a lot of parental support, having a lot of role playing, reading a lot, pointing things out, talking to them a lot. All of those things help fill in some of these gaps and will affect whether or not or how far behind they get, even if they're compared to a similar situation peer. For these next 2 slides, the items in orange are considered pre-linguistic. These are the items that I want you to pay attention to. I also want you to see and hear that it's these areas that, even though there may be a significant hearing loss, the child may still develop these skills. They still will exhibit startling to loud sounds, cooing and gurgling. At the 6 to 9 month age, if there is a hearing loss present, depending on degree again, you will see where some of this verbal play, where they're making sounds and kind of playing with their voice and repeating things they've heard and those kinds of things. If there's a significant hearing loss, that will slow down. That verbal play will slow down or stop. That's where they start to get into some of these other higher level processes where we will start seeing some auditory and speech-based delays. But again, a profound hearing loss infant will still meet some of these pre-auditory milestones the same as a normal hearing infant. Because of that, we have developed the Universal Newborn Hearing Screening Program. The goal is to identify early hearing loss that occurs in infants. Our goal is to screen each child by 1 month of age, diagnose the hearing loss by 3 months of age, and have early intervention in place by 6 months of age. We call this our 1-3-6. We also have recommendations set in place for children with risk factors for delayed onset hearing loss, family history, ototoxic medications, in utero infections, craniofacial anomalies. So even if they pass their initial screenings, we will still follow them to make sure something's not developing later on. Our goal, again, is to catch hearing loss as early as possible so that we can get interventions in place as early as possible. Early childhood intervention is a great resource for children and families that have hearing loss. This program or developmental delays, not just hearing loss. This program is in place for birth to age 3. There was a talk earlier this month by a UTMB speech pathologist that provided you information on how to refer to this program when you suspect there's a concern. ECI helps coordinate services for children. When they're in this group, they help make sure that it's family-centered, it's in a familiar setting, but they also help when they age out. So when they are moving beyond the 3-year-old group and getting them into the school district. ECI is also the coordinator for children that have hearing loss and or vision loss at birth, because they are required through the school district. Actually, the school district is required to provide services for them from birth. So ECI just helps get them into those programs and kind of keeps an eye on where they are. So they get kind of a double intervention early on, which is helpful. And then these following slides are provided to give you examples of what is normal development for a child of varying ages. What you can see here is that the 3 or 4-year-old is actually doing a lot of stuff. They're learning a lot of new sounds, but they may still substitute some sounds like wabbit for rabbit, whittle for little, because some of those, the R and the L are later developing sounds. And so they won't do that at 3 or 4 years old, but they will do that later. A 5-year-old should be building on what they already learned as a 3 and 4-year-old, and they've incorporated a few new sounds, but they're still going to have some difficulty with some of those blend sounds like our ch and sounds. They also are starting to understand word order and timing words. If there's a hearing loss in place, you will see that these children aren't meeting some of these milestones. These resources through ASHA and the CDC have a ton of resources that can be printed out, but there is information for parents, there's information for professionals, dependent on age, grade, there's just a gamut of information through these resources, and you'll have that available in your slides. So academically, if a child has hearing loss, there's going to be an adverse effect on their academics. If you can't hear the sounds being produced, then you're going to have a hard time replicating it in a spelling word or your reading comprehension. With and without intervention, children are still going to have some difficulty in some of these situations in the classroom because of environment. Reverberation is going to play a role. Noise level of the room, distance from the speaker, multiple people talking at the same time. So even if intervention is in place for these children in the form of amplification, they may still have some difficulty, and the normal hearing child may as well. Unilateral hearing loss is not excluded from the difficulty that can occur in the classroom. So despite having a better or a normal hearing ear, this child does not hear everything going on around him in class. He's not able to localize speakers. He's distracted by noise. He misses subtle cues provided by other speakers. They're also at risk for having fluctuating hearing in the other ear, the better ear, because of middle ear pathology, or down the road developing some changes in that good ear hearing as well. Children with slight hearing loss have been documented as missing information when presented at a distance or in background noise. When we're looking at large classrooms with 25, 30 kids, it's expected that they're probably missing more than what the slide even shows, which is 10% of the speech signal when the teacher is greater than 3 feet away. They may also be missing subtle conversational cues. They're not following fast-paced peer interactions. So if everyone's talking excitedly, they may not be following everything that's being said. Listening fatigue is going to arise for this group as well as all the others with more significant hearing loss, because they're having to put forth more effort to maintain their communication activity during that day. If the slight hearing loss child is already having trouble, the mild hearing loss child can be expected to be having more difficulty. They're missing 25 to 40% of the speech signal when it's presented at a close proximity. Classroom discussions, they may only be getting half because of faint voices, reverberation, classroom noise. They sometimes aren't able to tell who's talking because everything kind of gets blended together. Depending on the degree and the configuration of the hearing loss, they're going to miss consonant sounds, or they're going to need more volume. They too have listening fatigue. So this was just a graphic. We keep popping up this speech banana, but I wanted you to see. So this is a mild hearing loss overlaid over the top in the blue. They are not hearing all the quiet sounds or soft speakers, but they're hearing things that are at a normal volume or that's louder. If it's at a normal volume, keep in mind the environment's going to play a role here. So I have some sound bites. This is that normal listener that you were hearing earlier with the child's voice. So that's a child using a regular normal voice talking to a normal hearing listener. This is that same child talking to someone with a mild conductive hearing loss. I promise there was stuff going on. So you may not have been hearing it, but there was just kind of a little blip, 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 blip of speech. That's a mild conductive hearing loss. That's for that child listening to another child speak. This is a mild sensorineural hearing loss. There's a little bit of a difference in what you can hear. So even though all of these that we were just listening to were set up for a mild hearing loss, there was a little difference. The conductive hearing loss, to me, seemed like there was a little more volume there. The sensorineural, there was nothing there. I could barely tell that they were talking. So this next one, so that's just two people, average speakers, talking to each other in a quiet environment. Here's again with a mild conductive hearing loss, same speakers talking. And here's another one. This is that sensorineural. So here, what I'm hoping you're hearing is that when the couple was talking to a normal hearing listener, you're hearing everything pretty well. When you have a mild conductive or a mild sensorineural hearing loss, bits and pieces of that conversation were still audible, but other parts of it, no, but I couldn't tell what they were saying. And that's just a mild hearing loss. Think about what they would be for a moderate or a severe hearing loss. And here's one more example. Oh, I thought that was my train. This is actually them using a louder volume. So they're speaking at a much louder volume. And when they're putting much more effort, a mild hearing loss is a little more audible, but they're having to put forth more effort. So moderate or greater hearing losses in the classroom must be really struggling to hear if what those examples that I just played were just a mild hearing loss. General rule of thumb is that they're not hearing 50% or greater. So the further down the audiogram we go, the more difficulty that they are having. This is going to be dependent on the degree of the hearing loss again. It's also going to be dependent on the configuration. So if someone has a more normal low frequencies, but a more significant high frequency, there's going to be a variation in what they can and cannot hear. These children are going to need more support. They're going to need additional services. Amplification may be beneficial depending on the degree of the hearing loss for sound awareness, maybe for audibility. The other thing that we need to keep in mind for this group in general is that because it's a sensory neural hearing loss typically, not always, but because the greater hearing losses may be sensory neural, louder isn't always better. Louder is just louder. Louder is still not clear. Louder still doesn't get them all the information that they need. So they may benefit from additional cues, visual cues, written information, sign language when appropriate, those types of things. Safety issues also come into play for all of these children, but specifically these with more moderate and severe hearing losses, because those loud environmental sounds may not be loud environmental sounds to them. They may be seen soft or they may not be audible at all. So here I just overlaid some more color blocks, but this is for a moderately severe hearing loss, just kind of showing you what else is blocked out. So at this point, they're not hearing any soft or normal presented speech. And then some of the environmental sounds, like I was just saying, the piano and the telephone may be just audible to them, but they may not know what it is or not be able to identify it because it's too soft. And then the louder sounds, jet airplane, Mack truck, they are, but they may still, again, not be loud to this listener. And here's a severe hearing loss, same thing I'm trying to show you. Some of these super loud sounds like the Mack truck screaming at me because I'm standing in the middle of the road. If I had this hearing loss, I may not know that they're there. Sorry, I lost my page. So in the school-age child, we can expect that depending on the degree of their hearing loss, the configuration of their hearing loss and their type of hearing loss, that they may have some effects to their speech and language. We can also expect that there's going to be some effects to their academics because they may not be developing vocabulary as quickly as other children because they're not hearing some of the abstract words that are less meaningful. They are missing out on incidental listening, so eavesdropping or overhearing. We all learn from hearing what's going on around us. Children with hearing losses don't get that benefit. They miss out on an awful lot of incidental listening and incidental learning because they can't overhear someone next to them talking to somebody else. They don't get the example of two adults using more complex speech language patterns and vocabulary because they can't overhear it. Another example is a child that is profoundly deaf or severely deaf, severely hearing impaired, who maybe is wearing hearing aids but more for sound awareness, but uses manual communication as their mode of communication. If their families are not supporting that mode by signing all the time, even when they're talking to the adults in the room, that child is not getting that extra overlearning, overhearing, incidental observation of them signing to each other if they're not doing that on a routine basis. So again, academic achievement can be severely affected when intervention does not occur or if the intervention is not consistent. And that's at school, that's also at home, it carries over. And then here, this just goes over some old demographics that just says without intervention, children with mild to moderate hearing loss achieve 1 to 4 grade levels lower than normal hearing peers. Even with intervention, sometimes there is still that gap. The level of achievement is going to be related directly to parental and child involvement and buy-in. The child's not wearing their hearing aids at home and at school and all waking hours, they're going to be at a deficit because they're not getting as much of an example. They're not listening as much during the day because their hearing is preventing it. And also the quantity, the quality, the timing, and the consistency of the support and services they receive is going to affect their abilities. An intervention for any of these children can look like a number of things. There's medical management or evaluations that are needed, checking that they're understanding what's being presented in the classroom or at home. Sometimes it's not just an attention thing, and sometimes they just truly did not hear you. They need classroom and academic supports. This can be in the form of devices, teacher aids, one-on-one test taking, smaller groups for discussion, note takers, those types of things. Speech and language development, reading and writing, again, may still need additional resources. Amplification, if they're wearing it, got to make sure it's working. We have to make sure that it's set appropriately. If their hearing is changing at all, we need to make sure that that's accounted for. These children tend to do well with optimal seating, which is putting them closer to where they need to be, getting them away from distractions. Teacher education. If the teacher doesn't understand what the child is hearing or not hearing, the teacher, just like the parent, can't help that child if they're not fully aware of the situation. And then there's also some systems that the school can use to help overcome some of the background noise situations. Some of these, like the sound-filled systems, are helpful even for normal hearing listeners, given the acoustics of our classrooms and the size of our classes. So what about preventable hearing loss? So most everything that we were talking about today are hearing losses that we can't really do a whole lot about. We just have to figure out how to manage what we got. Noise-induced hearing loss, as we were talking earlier, 12 to 13% of children are identified as having noise-induced hearing loss. Noise-induced hearing loss is preventable with education and with the use of appropriately fit hearing protection devices. Noise-induced hearing loss can occur from a one-time exposure to a really loud sound or repeated exposures to lower level sounds. Typically, it affects the high frequencies, which are consonant sounds, which makes speech sound mushy if they don't have those high consonant access. Noise-induced hearing loss is permanent. It's also sensorineural. And it usually is accompanied by tinnitus and some oral fullness. So you can have some other things that are going on with that child that are distractions, especially during the school day. This is just a graphic of kind of the overall where damage can occur, those levels. So if we are consistently exposing ourselves to the items in red or even orange for long periods of time, or one-time exposures, we can be causing some damage to those hair cells. So what do we do to prevent noise-induced hearing loss? The biggest thing is education before the incident. Noisy Planet has some excellent resources for children and teens about hearing loss. And the other thing is cautioning and reminding people that, like earbuds and things like that, they don't need to be at full volume. And we probably should reduce our time. And then this lovely So they are trying to reach the teenage group by educating them about the fact that loud sound will damage those hair cells and get their hearing closer to an 81-year-old instead of a 21-year-old. The other thing that we need to be educating people about is hearing protection devices. They're readily available. Foam inserts, earplugs work well as long as they're placed well. They need to be worn during every loud exposure and every time, not just some. And if we miss it, or if the education doesn't get there, or they ignore it, then we have the after effects. So we need to monitor their hearing. We need to look at amplification or assistive listening devices as appropriate. Talk about communication strategies, implement good listening. Classroom management may also be needed. And again, still hearing protection device use when we are in those excessive noise situations. Social and emotional. So some of us know this and some of us forget, but there are psychosocial effects of hearing loss. This can be for the child, this can also be for the family. And this is something that can impact follow-up. This can impact your plan. This can impact kind of the child's achievement. So when families are and children are dealing with the psychosocial effects of hearing loss, you may find that they're not wearing their hearing aids. You may find that the parents put off pursuing hearing aids. You may find that they don't want to contact the school and let them know that their child has a hearing loss. Those things will happen because of the psychosocial effects. We have to be sensitive to that. We have to walk a very delicate line between pushing and respecting and hearing those concerns and recognizing them. The other aspect is that children with hearing loss, degree doesn't really matter, but they may be feeling socially isolated. They may be construed as socially awkward by their peers. A lot of that is because of the hearing loss. They don't hear subtle cues. They don't get that there's someone's joking because they can't hear that in their voice quality. And so that can affect some of their social interactions with others. And that's something can't really be taught, but it is something that we have to be aware of and try to help them navigate. Vocational factors are more for your older children, but your younger children, this will come into play too, because whatever they do in their early childhood and early education will affect later outcomes. If early elementary school and junior high are so difficult that they really just do not like school, it's going to be hard to get them to do well in high school, to want to go to vocational school or college afterwards. So we have to keep that in mind. We also need to try to give them the tools so that they can be successful no matter what they choose to do. When they are working, then we have to look at some employment factors. So their ability to interview. Again, if the interviewer has bad speech skills or it happens to be like we're doing a lot of right now, remote interviews or telephone interviews, people with hearing loss have a harder time. Once they get the job, access to the telephone, client interactions, those things, they'll maybe need some modifications, some additional devices and resources. That's all information that's out there, and there are resources available, but we have to get them in touch with the right people. Most states have even workforce commissions that help get hearing impaired people or hearing loss, people with hearing loss, the resources that they need so that they can be successful at work. And financial costs, as you can already probably assume, are associated with everything we've already talked about. There are intervention costs, there are education costs, there are employment costs, lost wages, those types of things if they're not working. Everything has a cost. Hearing aids have a cost and you'll need new ones every couple of years. Insurance does not always cover these costs, and so that can be a blow to a family who is already trying their best to do with what they have. So these are things that we have to consider. There's never an easy answer on how to handle them, but this will also play into the child's success. If financial costs are too high, then they don't get the services that they need. Summary of everything we've already talked about: delayed intervention causes delays in receptive and expressive language, can cause learning difficulties, reduced academic achievement, lead to social isolation and poor self-concept, and can impact their educational and vocational choices. But there's good news. There are a team of interventionists is what I'm calling it, team of people that are ready and willing and able to help guide families down whatever road that they are on. We have our pediatricians and our ear, nose, and throat physicians, clinical audiologists and educational audiologists, teachers, special education teachers. We just have to make sure that everybody has the tools that they need so that they can help these children in the best way possible. And early identification and early intervention at this point seem to be extremely key. they are not guarantees that everything will be overcome, but the earlier that someone is identified, the faster that they will catch up when there are delays, and the hope is the less negative impacts we will see down the road for that child. And what is your role? Your role can be simple as referring, providing treatment for manageable hearing losses, and doing genetic workups or imaging or blood work when there's a hearing loss that is identified of a permanent nature. Also, sharing information with the educational and the clinical audiologist. I added educational audiologist here because sometimes there's a question like, why? You already have this, why do I need to send this somewhere else? The educational audiologists are with the schools, and so they are focusing on the educational impacts of the hearing loss and making sure that the child is getting what they need. They have their own requirements for paperwork and what they need from you, versus the clinical audiologist who can get that pretty readily. So when you're getting asked for information from two sources and it seems like it's the same, that's why there's a difference. The educational audiologist is purely looking at the academic and the classroom situation. The clinical audiologist is looking at what you need, but also looking at the devices and billing insurance and that type of thing. Refer for audiologic testing when there's a refer on a newborn hearing screening, or a refer or a fail on a school or PCP hearing screening. If the parent voices concerns, we should probably heed it. Sometimes there's something going on. And then if there's any concerns for speech or language delays, we should look at that. Same thing here, otologic concerns. Sometimes those are easy things to manage, sometimes they're not, but if we can get them in and get them evaluated, then our hopes are that the impact will be limited. Amplification, tons of devices out there to help even our slight, and in some situations, some of our normal hearing listeners in the classroom, just because of the acoustics of the environment. Is there a right or wrong way? I don't know. The only thing that I can say is that the only wrong way is to ignore any of those warning signs, to ignore your spidey senses, to ignore the parent and tell them that they're going to grow out of it. Sometimes there's something actually going on and we should probably heed that. Otherwise, I think any other way is right as long as the child and the family is kept in the forefront as the main goal, giving them the services that they need. So our take-home messages here, just another beautiful audiogram, just to show you that communication difficulty can occur anywhere along this audiogram: normal, slight, mild, severe, profound. The impacts can be far-reaching, they can be long-standing if they're not addressed, and if parents aren't provided resources. You and I are the key to providing those resources and giving these children the services that they need. We need to be aware, we need to be mindful of our spidey senses, and we need to look at our screening and our normal development to determine what we should do. Thank you for your time. Any questions?